So, dann fangen wir an. Komm mal vor.
Okay, so we'll get started.
Wir haben es gar nicht geübt, gell?
We didn't actually practice, did we? We never practiced, but you can do it. Shall I hold the microphone for you?
Brauchst nicht. Soll ich das Mikrofon festhalten oder willst du?
You hold it, great.
Kann ich anfangen?
Ja. Halt schön an den Mund dran.
Close to your mouth.
Hallo liebe Gäste, ich heiße Sarah, bin 12 Jahre alt.
Hello, my name's Sarah. I'm 12 years old. I'm from Alzey, where I live with my family. And next we'll hear the presentation by Meg Hefner from the United States on Charge Syndrome, Charge 101, an overview of all the characteristics. Or in German, Charge from A to Z. This presentation will give us an impression of the complexity of charge and all of the syndromes, including a charge simulation.
Hast du super gemacht.
Thank you for that lovely introduction. I'm very pleased to be here. This is my first time at the German Charge Conference, and I'm very excited to talk to you all and to kick things off and introduce some of the things that you'll be hearing about later in the weekend. So my name is Meg Hefner, and I am a genetic counselor from St. Louis, Missouri. And although, like many of the speakers here, we've been involved with Charge for a very long time, I'm retired from my clinical practice as a genetic counselor, but I remain very involved with the Charge Syndrome Foundation in the U.S. and with Charge families. So today I'm going to be giving you an overview of the features of Charge Syndrome, especially those involved in making a diagnosis. But first, a little bit about me. Who am I? My training is as a genetic counselor, and that's a relatively new field, less new now. I'm not a doctor, but I work with the medical team and the medical genetics team. My role in the team is to help families understand the medical information and understand what the various medical specialists are thinking, what kind of tests they're thinking about doing, what information we can and cannot get from those tests. So a lot of sort of interpretation of medical information so that it's understandable to the families. So a lot of this includes genetic information, testing, what to expect in the future. So functioning as an interpreter between the doctors and the family. And a little bit about sort of how long has Charge been around, how long have I been around, and this is also true of many of the speakers you're hearing at this conference. The name Charge first came up in 1981, so a little over 40 years ago. I started working with Charge in what was originally a general deafblind project, became a Charge project in 1982, so right on the ground floor. And, okay, I need to figure out. I'm just figuring out that what I can see on here isn't all showing up. So, I started involved in Charge in 1982. We first wrote a booklet for families in 1987. We started a newsletter, a paper, mailed out newsletter in 1989 because this was before the internet. And in 1993 was the first time we got families together for a conference in St. Louis. And I was also a member of the team that started the Charge Syndrome Foundation in Missouri in 1993. So I've been around for a really, really long time. And that means I've seen the diagnosis change. I've seen more families come into it. I've seen children grow up. And this is Philip has been to almost every single conference. I now make sure I get a picture of him at every conference. So I've seen these families grow up. This is Philip over about 20 years, and you see he's gone from a young child with his teeth missing to the young man with the beard in the lower right. So this ranges from about 20 years. 1919, I also saw him last year at the conference. So what am I going to be talking about today? This presentation will be an overview of many of the medical features of CHARGE. So even if this conference were stretched into a week, we couldn't cover everything in CHARGE. You all know it's way too complicated. So what I'm going to be talking about is a little bit of the history and the epidemiology and the genetics, sort of where does CHARGE come from, how often does it happen, and then spend a lot of time on the diagnostic features. And those are really the features of CHARGE that are a little bit different than other similar genetic syndromes that help us distinguish, is it CHARGE or is it something else? And it's important to note that these aren't necessarily the most important medical or developmental features. They're the ones that help the medical geneticists, the medical team, make a diagnosis of CHARGE or some other syndrome. I will also be mentioning some of the other features of CHARGE that are perhaps more important medically and developmentally, but are less important for the diagnosis. So I'm going to run through, and I can't cover every single feature with CHARGE. There are too many, but I'll be going over a lot of the more common ones. And a lot of this information that I'm covering is available in English in a paper I published a while ago called Genetic Counseling in CHARGE Syndrome. And that is the American Journal of Medical Genetics from December of 2017. That entire issue was devoted to CHARGE. And there are other articles in there about different parts of CHARGE, including ones authored by other presenters at this conference. At the CHARGE Syndrome Foundation website, you can find summaries of all of the articles, as well as links to the articles themselves that you can download for yourselves or for your child's medical providers. So a lot of this information is available in a number of different ways. So where does the name CHARGE come from? It's an acronym. Each letter of CHARGE came from one of the features. The acronym, a bunch of geneticists were sitting around in 1981, and they had recognized, they weren't sitting around, they had recognized that there were a bunch of children that seemed to have the same thing. And they said, how do we describe this? It's really complicated. Let's see if we can come up with a clever name from some of the features. And they came up with this name where C stood for coloboma, H for heart, A for atresia of the choanae. They had to kind of say it backwards in English to get it to fit into the A. R was retardation of growth and development. G was genital urinary anomalies. And E, ear anomalies and hearing loss. And that was never meant to be a be-all and end-all for diagnosis. It was a starting point. Even in that paper in 1981, they said this CHARGE doesn't cover some of the most important features, which are the cranial nerve problems. So it's a lovely name, it's a positive name, we don't want to change the name, but we really don't use the features as a diagnosis or really to describe the syndrome very much. How often does CHARGE happen? It occurs about 1 in every 10 to 12,000 births. And if you put that into context in Germany, if you look at the birth rate in Germany, that means that we would expect about 60 or 65 new babies with CHARGE every year. Obviously, we're missing a lot. If the 100 families here at the conference, and there were 60 new ones just last year. So it's out there. There are a lot of people that haven't been involved in things. It usually does not run in families, so the child with CHARGE is usually the first one in the family to have it. Most of the time, CHARGE is caused by a variant or mutation in the CHD7 gene on chromosome number 8. And that gene was identified in 2004. So if you go back, I started working with CHARGE in 1982. We started the CHARGE Foundation in the US in 1993, and then, so 10 years later, and another 10 years later, we found the gene. It's now been around for long enough that people are familiar with it. CHARGE is the most common genetic cause of congenital deafblindness. And that means there are a lot of different ways you can get combined hearing loss and vision loss. Of the ones that are genetic and present at birth, charge is by far the most common. And that means that most geneticists and neonatologists, doctors that work with high-risk pregnancies, babies with problems, and geneticists are very familiar with it. So they should all be familiar with it at this point. The first 10, 15 years of my career was getting it on the radar, making them aware of it. So, does it ever happen again? Whoops, I'm sorry. I'm looking at the wrong slide here. When I say 10 or 12,000 births, how many people out there have charge? That's very hard to get a handle on. And that's because of several things. What's the mild end of the spectrum? If someone has a change in the CHD7 gene, but all they have is balance and hearing problems, do they have charge syndrome? I would say no. Some people would say yes. There's not always agreement on that. So where do you draw the line of what's the mild end of the spectrum? On the other end of the spectrum, there are babies with very severe birth defects who die either during pregnancy or very shortly after delivery before they're diagnosed. So there are potentially people at both ends of the spectrum that we miss. Many people with charge have very severe heart defects and breathing problems and die in early childhood. And so if you're looking at how many people who are 15 years old have charge, well, that depends on the mortality. So it's hard to get to know exactly how many people there are out there with it. And also the people that are doing very well are less in need of educational support, less in need of family group supports. I had a lot of situations, especially in the early years, where I'd get an email from an adult saying, I think I have charge syndrome. I had all these things going on when I was younger, and I got past them, and I'm doing this, but when I look back, I think it's this. And many of them were right. And they're not involved with these kinds of groups because they're out there living their lives. So it's really hard to know how many people are out there with charge. I will say that in terms of the mortality in childhood, the highest mortality is among the children that have complex heart defects along with breathing problems. That's very difficult to get past. And unfortunately, the health of people with charge can remain fragile throughout lives. Sometimes families have asked me, when can I stop worrying? And I kind of have to say, you can't. There's things that can happen, unexpected things that can happen. I mean, that's not just true of children with charge or adults with charge, but it's especially true in this group. Does charge happen again in a family? It does sometimes. And with genetic testing, you can do testing and see if either the parents carry the same gene that the child has. Even without that, there is a chance of it happening again. The genetics of charge is an entire additional talk, so I'm not going to go into a lot of details, but the change in CHD7 that causes charge can happen in the child who has it. She could be the very first one that has it, or it can happen in the sperm or egg that formed that child, and there could be other sperm or eggs with that same change. That means that even if parents are tested and they're negative, there is a 1 to 2% chance that it could happen again in another child. And that's the case with this family. This young man sitting down here is their first child. He has charge. They then had a son and a daughter who don't have charge. The babe in arms also has charge. The parents are not carriers. The two children have the same mutation, so it was carried in the sperm or the eggs of the parents. This family has actually gone on to have a fifth child who does not have charge. If someone themselves has charge, they have the change in the gene, and they have a 50-50 chance of passing that gene on to their child. How that gene will show up what kind of problems they have is very, very unpredictable. So the chance of it occurring and what it means when it occurs are different questions. More extended family members, siblings of people with charge, aunts and uncles, cousins, their risk should actually be very low. And this is a family that I saw 40 years ago in Missouri, that we had 5 affected individuals in 3 generations. So up at the top we have the grandmother, and I don't know if she had more than these 2 children, but she had these 2. Her son at the time was living with her and wasn't working. He was in his 30s at that time, but he didn't have any education that took into account the fact that he was completely deaf. This woman's daughter had a total of 6 children. 2 of those children died in infancy, had major birth defects, probably due to charge. She had 2 children who were completely fine, unaffected, had children of their own who were fine, and then she had this son who was the one who very obviously had charge. He's the one that brought the family to our attention. He had clear charge. His older sister also had charge. She was in high school when we saw her. She later married and had children. So this shows you everyone in this family has the same gene, but it showed up differently. Everything from babies with birth defects so severe that they didn't survive, to women who grew up and got married and had children. So, and that's even with 40 years ago in very rural Missouri, where there was no education appropriate to people with hearing loss and vision loss. So extremely, when it does run in a family, it can be very variable. Okay, if we don't use CHARGE for the diagnosis, what do we use? And this is going to be the majority of my talk here. What we use are what we call the clinical diagnostic criteria. So clinical criteria, those are things that we can look at or that we can test for. And what we want are features that help us. As I say, you've got a baby and they've got multiple things going on. You call in the geneticists and they're looking at their list of syndromes, and what you want is information that helps us determine, is it this syndrome or that syndrome or another syndrome. And actually, if you're interested in what other syndromes have features that can also look a lot like charge, that genetic counseling in charge paper that I mentioned has a table. And at that table, we have all the features that you see in charge syndrome, and several other syndromes, and how common each of those features are in the different syndromes. So you can see a little bit of what the thought process is for geneticists. When we've done this diagnostic criteria, and this was done with a group of people at the U.S. conferences, including the people who are here speaking at this conference, we broke things down into what we call the major features and the supporting features. Major features are ones that are common in charge, but relatively rare in other syndromes. So again, helping us distinguish. We want things that are recognizable early in life. There may be some things with charge that are very typical of charge, but if they don't show up until they're 5 or 10 years old, that doesn't help you make a diagnosis in an infant. The supporting features may be very significant, may be very common in charge, but they're so common also in other syndromes that they're less helpful in distinguishing between charge and other conditions. And there may be other things that are significant when they're there, but they're not there as often. So that's sort of how we distinguish these things. A lot of times people just go straight to the DNA and they say they've got the DNA change, this must be charge. DNA by itself is not enough. That's one of the pieces of the puzzle, and I'll be saying that several times through this talk. Clinical diagnostic criteria, where you're looking at these lists of things and seeing which features they have, is really the best way to do it. So, what are these major diagnostic features? Instead of using the CHARGE, We have sort of 5 categories, and each of these categories has several different ways you can kind of check it off. But these categories are coloboma of the eye, choanal atresia or cleft palate, cranial nerve anomalies, characteristic ears, and CHD7 mutation, the genetic change. And in order for you to really be in a category where you say charge is a possibility, you need to have at least 2 things that fall into these categories. And if you only have 2, you also need some of the supporting features, and it's kind of a mix and match menu. And again, the genetic counseling paper tells you what other syndromes are most likely to be confused with charge. So I'm going to go through each of these, and you're going to hear more about many of these features from some of the other talks through the weekend. The first is the coloboma of the eye, and David Brown's going to give you a lovely description of this and how it affects things later on. But basically, when the eye is forming, the eyeball forms around, and it kind of zippers closed at the bottom. And if there's a problem with that zippering closed, if there's a cleft in the eyeball, that gives you a coloboma. And that can happen anywhere from the very front of the eye with the iris. It can happen in the retina, and it can happen in the parts of the retina, the macula and the optic disc. Each of those have different implications for vision. So here's some pictures of things. The iris coloboma is where you have a gap in the iris, and that means that you have a keyhole-shaped pupil. What does that do? That doesn't change how clearly you see things. It does not change visual acuity. But what it does change is how you react to light. If you go out in bright light, your pupil contracts and gets very small, lets in less light so that you can see better. If there's a gap in that iris, then you can't do that. You can't contract that way. You can't keep all that light out. And that's why kids with iris colobomas are very sensitive to light. And they may even want to wear tinted glasses, sunglasses indoors, because their eyes are not controlling the amount of light that comes in. If the coloboma is farther back, it's in the retina, and this is it's hard to see because it's kind of bright in here. This is a photograph of the inside of the eye. It should be red with lots of blood vessels everywhere. And you see this white area there. That's the coloboma. This is a visual field test he was 16. This young man was having this test because he wanted to drive, and we had to find out if he had enough vision to legally be able to drive in the state of Missouri. And I'll tell you, you only have to have vision in one eye in the state of Missouri to get a driver's license. I would not recommend driving around this guy. Normally, when you do a visual field test, you have a circle. You see all around. Everyone has one little blind spot. What's missing here is his upper visual field. And David will do a really nice job of explaining how things the way things get flipped over in your eye. When you have a coloboma in the bottom of the eye, what that does is it interferes with your upper visual field because the image is flipped. So if you have a retinal coloboma like this, it's as though you have a baseball cap and you've pulled it down. And that means that you're not seeing what's up here. What you're seeing down here, you're seeing, it may or may not be clear. A lot of kids have problems with that as well. But so what do kids do with that? They use the visual field they have. It's like me looking through my bifocals. I tip my head back. So you get this upper visual field defect, and kids will position themselves to use the vision they have. And I think about this a lot. The language that we use is really not as precise as I would like. We talk about visual loss. If I suddenly developed a coloboma, that would be a loss for me. for these kids, it's not a loss. It's their normal. They don't know that other people see things in different places than they do. And the example I came up with that is you get somebody who comes down from planet Xenon and they say, "Oh, Meg, you don't have eyes in the back of your head. Oh, I'm so sorry, you have that visual loss. What do you do?" And I say, "Well, if there's something going on back there, it's out of my visual field. What do? I move and use the visual field that I have to see it." Not having eyes in the back of my head is not a loss for me. It might be for somebody who has that to start with. So for these kids, it's different. And we need to know it's different, but it's not a loss for them. It's their normal. And so that's, all of these things are their normal, and it helps if we can understand that and just adjust ourselves to their normal. Everybody thinks that, it's normal to sort of think that everybody hears and sees and thinks the way you do, that's normal. It's part of the growing up process to figure out that people experience the world differently. So children will position themselves to use the vision that they have. And that can be really important. It's important for everyone around them to know what the visual field is. If they're learning sign language and they're lower down and you're signing up here and they have no visual field up here, you might as well be in the next room. Know where their visual field is. If you ask the eye doctors, they'll say, "Oh, well, we're really not sure." If you push them, they can look at the retina and know where the coloboma is, and they can make a good guess about where the visual field is. So get the information that you can and make sure everybody working with your child is aware of this. Now, any coloboma in the retina makes it a little more likely that the retina could detach. If you have a detached retina, that's going to cause complete blindness in that eye. If a retina is starting to detach and you catch it, that sometimes can be repaired. So the other thing to ask the eye doctors is what changes in behavior might signal a detaching retina. For adults, it's things like flashing lights, changes in vision, that kind of thing. But children who can't communicate, you may be having to look for what behavior changes there might be, because if you catch it in time, it might be fixable. I'm showing, depending on where the coloboma is, you have different kinds of field loss. If the coloboma is in the macula, and again, David will talk about this a bit, that's the part of vision that's your central vision, your very fine vision, what you use for reading. If the coloboma's there, you're not seeing the stuff in the center. You're using your peripheral vision to see things. And that means you're not going to appear to be making eye contact. And a lot of our interactions have to do with, you want the baby to look you in the eye. You want children to look you in the eye. If they're looking if I'm looking at Tim this way, he thinks I'm looking over there because that's where my eyes are aimed, but I'm using my peripheral vision to see this. So if someone has a macular coloboma, they're missing their central vision, you need to know they may appear to not be paying attention, but they might be. In this child, it's made worse by the fact that she has a bilateral facial palsy. And I'll get to facial palsy in a few minutes. But basically that means she doesn't have the nerves that animate her face. So she looks like she's looking off to the side and she's not paying attention. She might be attending very acutely to what's going on. So knowing what their status is so that you know what signals they're able to give you is really, really important. So know what your child can see and not see, and make sure that people working with them know what's going on. So that's the first of these major features. The second is choanal atresia. The choani are the passages at the back of the nose to the throat that make it so that you can breathe through your nose. And those might be blocked, that's an atresia. They may be narrowed, that's a stenosis. It may be bilateral on both sides. It may be unilateral on one side. If a baby's born with a two-sided blockage, that's an emergency because little tiny infants have to breathe through their nose. That's how they can breathe and eat at the same time. If it's blocked up and you don't prop their mouth open to breathe, they'll suffocate. So that can be very important. A bilateral blockage is usually fairly obvious at birth, and you get surgery, and they put in stents, little tubes, to hold it open, and they often need to dilate that. Sometimes it closes down. You need multiple surgeries. About half of all children with charge are born with some kind of problem in the choanal atresia thing. About 80% have colobomas, very common in charge, very rare in other features. Choanal atresia is less common in charge, only about half, but it's so rare in other syndromes that when it's there, it's really helpful. The hardest thing to diagnose is a one-sided narrowing. You can still breathe through your nose, just not as well, but what that can do is gives you often a sort of a goopy nose. You can't really see it, it's not dark enough. She's got a really goopy nose on one side. That isn't as important you don't necessarily have to do surgery to open it up, but that's going to make her more likely to have ear infections and fluid in her ears and ear problems because things are not flowing out as well. So the one-sided stenosis can still be important to look at. Okay. The third category is a big one. It's the cranial nerve anomalies, and this can be any of the cranial nerves. There are 12 different cranial nerves. I'm only going to really, in this part of it, talk about a few of them. Probably all of the cranial nerves are affected in charge, but we have not done as thorough a job of really investigating what's going on with the rest of them. We pay attention to the ones that have more obvious effects. So there are 12 of them. They're numbered 1 through 12. Number 8 is the sensory neural hearing. I'm going to talk about that one under ears, although that is really a cranial nerve problem. I'm also going to be talking about cranial nerve 7, which is the facial nerve, 9 and 10, which are involved in swallowing, and cranial nerve 1, which is the sense of smell. If we look at all the cranial nerves together, all 12 of them, probably 95% of people with charge have one or another of them affected. Cranial nerve 7 is the facial nerve that I mentioned with the young lady with the macular colobomas, and it, again, animates the face. So if you can have a facial palsy on one side or on both sides. If it's there, it's usually present at birth. I have seen it develop in the first year of life in some children. I haven't seen it develop after that. If it's on one side, you get this lopsided face, and I'll show you her again in the next slide. This again, if it's on two sides, you have a face that really looks very, very bland. You don't have the smile creases. You don't get much expression with either smiling or crying. This little girl here socially knows that smiling is important, and so she is physically pushing her cheeks up to get into that position because she's figured that out. Besides the facial expression and how that changes social interaction, if you've got a palsy of that, and especially if you've got cranial nerve things also involving your tongue, that's going to mess with feeding and speech as well. And so speech therapists working with children with charge need to be aware that there are cranial nerve anomalies that may make it difficult or maybe impossible to make some of the movements that we normally do in speech. What I've done here is I've taken the lopsided face and cut it in half and I didn't do as quite as good a job on that. I'm not so good at Photoshop as some of you guys probably are. But you can see here the difference between this and this. If both sides of her face looked like that, you'd say, oh yeah, she's smiling, she's happy. This one, it's less clear. This one, it's really not clear. So you can really see how even a unilateral, it doesn't just make you look lopsided, it really changes how you're able to express what's going on. And since communication involves all that back and forth, any of you who heard Julie's lecture this morning was really talking about that. It's really important. So being aware that there are things that some of these kids simply cannot do is important. Don't expect it of them. Another, the very important cranial nerves, the cranial nerves 9 and 10. And these are the ones that are involved in the coordination of suck and swallowing. And you're going to hear a lot about the gut and that whole system from Kim Blake later this afternoon. But I'll just say that the swallowing problems that a lot of the people have, those are cranial nerves because the cranial nerves come and that coordination doesn't happen properly. A lot of children end up needing gastrostomy tubes, tube feeding either to the stomach or to the intestines. Most outgrow that eventually. You'll hear more about that. The feeding you're going to hear a lot about this weekend. Some continue to be G-tube fed throughout their lives, partly sometimes because it's simply not safe for them to swallow, others because it takes so much time to do it. I know a young man who was G-tube fed, and I asked him about it, and he said, I can eat pureed food orally, it takes so long, I have other priorities. So he uses the G-tube. When he got to college, he realized that eating was a very social activity, and so he did do some oral eating while in college so that he could participate in the social activity of feeding. Many adults with charge continue to have problems with stuff going down the wrong tube. Choking can be an issue throughout life. So those problems do usually get better. They don't always go away completely. And you all know, I'm sure many of you know about G-tubes and surgery for reflux. I'm not going to go into all the feeding problems, but they're very complicated. They're nerve-based. They're not because people don't want to eat. One that's less obvious is the sense of smell. It's probably very, very common. Probably 95% of people with charge have either a reduced or absent sense of smell. It's hard to test. It's really hard to test, but we've done some good testing and we know that it's very common. You think about, okay, you don't have sense of smell. One thing that's reasonably obvious is that's going to change your experience with food. It changes. Taste in charge may be normal, but taste on your tongue is sweet, sour, salt, bitter, umami. It's really everything else that we describe as taste or flavor comes from smell. And probably everyone has had the experience of having a cold where their nose is stuffed up, their smell is not working well, or if you had COVID maybe, that it changes your experience with food. So you've already got these swallowing problems and oral aversions, and now food isn't particularly interesting anyway. Hard to get people to eat. This lack of sense of smell also explains why some of the kids with charge have really odd food preferences. They like salty things, they like sour things, they like hot food. Well, that's where they're getting the sensation. If they don't have any smell, they're getting all their sensation from taste, so they're getting more sensation from that. So if you got kids that have really weird things that they like to eat, that may be part of it. Things that are maybe less obvious with sense of smell. Safety concerns. Think about smoke, spoiled food. One of the adults with charges told me, well, when she puts leftovers in the fridge, she always puts a date on them, and after a certain number of days, she throws them away because she can't smell it and tell if it's spoiled. Real safety concern there. There are also many, many social implications. Think about smelly feet, body odor, passing gas. If you have no sense of smell, how do you know that stuff even exists? It's like somebody trying to explain the fourth or fifth dimension to me. So things that children learn, that typical children learn incidentally. Oh, if I don't wash my feet, or if I've been passing gas, people don't like it around me. If you have no sense of smell, you don't even know that exists, and you certainly don't know that it's unpleasant for people around you. So that sort of thing has to specifically be taught to kids. You have to, it's not, you can't count on incidental learning that you can with other kids. And just as an aside, again, this is an entire extra different talk. If there's no sense of smell, because of the way the nerves and endocrine organs and things in the brain work, if there's no sense of smell, that child will not go through puberty on their own. They'll need to be given hormones. The hormones won't be produced by themselves. So that's a clue. If your child doesn't have a sense of smell, every child with charge should get followed by an endocrinologist in any case, but that's one that you'll need to do for puberty. So that's all I'm going to say about the cranial nerves, except that probably all of them are involved, and hopefully in future years we'll do more information about them and tell you more about what those mean. The fourth of these major categories is the characteristic ears. And that can be outer ear, middle ear, and inner ear. And so I'm going to go through each of those in order. The outer ear, as you all probably know, in charge is often very, very unusual. Something like this, if I just saw that ear, I would say this child has charge until proven otherwise. There's nothing else that gives you that ear. So when it's present, it's extremely helpful to have. And in fact, these ears are so distinctive that I can look at these ears and I can tell you whose ears they are. When I'm looking at things, and it's the whole range. I've also seen children with charge whose ears are completely normal. Don't look any like, they look like their parents' ears. One of the things that I've really noticed is the ears are often asymmetric. These top two are the left and right ear of the same child. So they're both abnormal, but they're not identical. So they're usually different from each other. Geneticists like to look at all the different parts of the body very carefully and very thoroughly describe things. So we have names for all these different parts of the ears. So what we see here, and I can't read it on the German, we often see a very small or absent earlobe. So no earlobe, attached earlobe here. We see the ears are often very floppy. The cartilage in them is not as stiff as you would expect. That can be a problem for keeping hearing aids on. We often see what we call a triangular concha, and that is this part of the ear here is a very triangular shape. This outer fold is the helix, this is the antihelix, and this antihelix is often at an angle that makes this very triangular. And when we look at some of these, you don't need to know all these different things, just know that we look at these a lot. It often looks like the outer fold is missing or as though someone clipped it off. Again, you see very prominent here, missing lobe. Discontinuity between the antihelix and the antitragus. This is the antihelix, this is the antitragus, and there's a gap. There's a gap. There's a gap. The cartilage isn't continuous there. So it's just something, it's part of why the ears sometimes fold over. And this part of the ear here is often very small. And I also will say, the external ear does not predict the hearing. You can have a absolute classic charge external ear and relatively mild hearing loss. The one child that I presented at a meeting a few years ago, because she had absolutely none of the facial ear. You look at her and there was absolutely nothing that said charge, but she had a profound hearing loss. She had she had all the internal features. So the external stuff does not predict what's going on. So the ear shape can be important for holding on a hearing aid. Otherwise, it's helpful for diagnosis. It doesn't matter otherwise. Moving from the outer ear to the middle ear. So you go in the ear canal, and then you have the eardrum, and you have all the little bones. The eardrum vibrates and moves the little bones, and the little bones send the signal to the inner ear. So the middle ear is the eardrum and the little bones, and that space in there that is not supposed to have fluid in it, but often does. And then you've got the eustachian tube that is a connection between the middle ear and the throat. And the way that's supposed to work is if there's fluid in the middle ear, it's supposed to drain down that eustachian tube and go away. And if your head is long enough, that works. Kids with charge have very square heads. The eustachian tubes don't point down, they're horizontal, and so they don't drain. And that's why you get that buildup of fluid, which makes it more likely you'll have ear infections. And the way that gets treated is you put a little hole and a tube in the eardrum, drain it out the other way. How many of your kids have had tubes in their ears? How many had more than one set of tubes in their ears? Yeah, it's like my kids who don't have charge had tubes in their ears, but once they were out, they'd outgrown it. Kids with charge often need them till they're 10. Any of those things you can have abnormalities with the little bones. Any of those things will give you what's called a conductive hearing loss. That sound isn't being conducted into the nerve system in the inner ear. So that will be so problems with the middle ear give you a conductive hearing loss. That's often treated with bone conduction hearing aids, where you're vibrating the skull to kind of bypass the structures in the middle ear to get sound to the inner ear. Moving to the inner ear, there are several different things that can go wrong. One very important one is the semicircular canals. And I'm not going to I'm going to say a bit about this. You'll hear a lot more. These are very, very important. And you'll hear a lot about this from David Brown, I think on Sunday, or whenever he's talking. David's going to talk a lot about this and really expand on this. And I'm really glad, because this really needs to be talked about many times. If there's no one feature that every person with charge has. This is the closest. So I do know of one person with charge that has normal semicircular canals, but everybody else has either small or absent semicircular canals. What are those? Well, that's the inner ear portion of the balance system, the vestibular system. And that, here. So there are these they're fluid-filled spaces. They're sort of an internal level. There are 3 of them that are at different angles, and they tell you where your head is in space. Is it to the side? Is it back? Is it up, down? It helps you orient in space. And so when that sort of thing is small or absent, you have a really hard... Back up a little bit. The balance system, as David will talk about more, involves the vestibular system in the inner ear, your vision, being, how it's harder to stand on one foot and keep your balance if you close your eyes, because your vision is giving you information saying where you are in space so you can stay upright without falling over. And you also get information from your muscles and your tendons. That's called proprioception. So all those things need to work together to give you balance. If your inner ear part is missing, you need to use what you have of your vision, and you may not have very good vision, and the information from your body to figure out where you are. And that's going to change how you move about in space, how quickly you do things. You're having to learn to do something with a big piece missing. And that's why kids are so slow to do a lot of the motor things, and the obvious thing is walking. They walk late not because there's anything wrong with their brains, but because they're having to figure this out with a big piece of the information missing. And I'll come back to some of that later. Let's see where I am here. But to go on, and this is something that is diagnosed by doing imaging, MRI or CT scan of the inner ear. If your child is getting brain imaging from an MRI or a CT because they want to look at the brain, when they're just looking at the brain, they look at it to hear. To see the inner ear, they need to look at it to hear. So make sure you don't always want to put them under sedation just to look for that. But if they're having it done anyway, make sure they get all the views that give them the information so you know what's going on. But if your child has charge, assume that the semicircular canals are messed up, because they pretty much always are. Okay. And what you get with that is this very characteristic development. You get, and again, David's going to talk about this, kids stay very close to the ground. They creep or crawl on their elbows. They may do a 5-point crawl where they're on their hands and their knees and their head. They may do a bottom shuffle. They may lie on their backs and push with their legs. They're doing what they can to get around while they're figuring out how to get upright without that part of the balance. And the age of independent walking is, this is something that I thought was really interesting. We knew that the average age of walking in kids with charge was about 3. We weren't quite sure, kids are in the hospital for a long time. There's a lot going on. So what is it about this? And what I looked at was children that don't have any of these problems, when they pulled a stand and they're cruising, walking around furniture, holding on, it's about 1.5 to 2 months before they let go and walk on their own. Kids with charge, when they pulled a stand and they're walking around holding on to things or holding on by a hand, it's 1.5 to 2 years before they let go, because they need that little bit of extra information to not fall over. They want to get where they're going. They don't care if they're holding on as long as they can get where they're going. So that is the most important reason for the delay in walking, is that big part of the balance system is missing. And they're smart enough to find workarounds. They figure out how to do it without it. So very important part and very common part for charge. So continuing on the inner ear is the cochlea, and that is this snail-shaped organ. That is the sensory neural hearing organ. Normally, in most people, there are 2.5 turns to that. Kids with charge, there's often 1.5 turns. That's where you get the sensory neural hearing loss. And cochlear implants can be very helpful for that. It's very common in charge. It's the sensory neural hearing loss. Behind the ear hearing aids help with sensory neural hearing loss. Cochlear implants help with sensory neural hearing loss. Just be aware that the hearing that you get with either of those is different from the hearing that you get when you don't have any problems at all. One of the things that puzzled me was, okay, if there's only 1.5 turns, if you put a cochlear implant in and you're still missing that turn, how could you end up with hearing across all the different frequencies? And what the audiology people told me, the guys that do the ENTs that do that surgery, is that the brain figures it out. and manages to get you hearing across, at least some type of hearing across the spectrum, even though there's still a piece missing. That's kind of magic to me. The brain does amazing things. From there, the sound goes through the cochlear nerve to the brain. So you can have problems with the middle ear and the sound getting to the cochlea, the sound in the cochlea, and then it's got to go to the brain. And if that nerve, that's where we go back to the cranial nerve anomalies. If that nerve is small or absent, that message has nowhere to go. So when someone is being considered for a cochlear implant, they have to do imaging and make sure that there is a nerve there. Sometimes they're not sure. It can be small, it can be very hard to see. I've known kids that have had cochlear implants where they've been told, we're really not sure if there's a nerve there. If there's not, this isn't going to do anything for them. And sometimes there has been some hearing and sometimes there hasn't. So you can have problems even at that level. And back to cranial nerves, so we've got the cochlear or auditory nerve here. Right above it is the facial nerve, the facial palsy nerve. And that nerve is right there, goes through the inner ear, and it sometimes goes through in places that it's not supposed to. We call that ectopic, if something is in a place we don't expect it to be. If you have a normal facial nerve, the last thing you want to do is damage it. So it's really important if someone's having a cochlear implant that they have imaging and that they're very careful that they know, and kids with charge, that facial nerve may be in an unusual place and be particularly careful to not damage it. So with all this, what's the hearing like? Most kids with charge have what we call a mixed hearing loss. And that means there's both a conductive component and a sensory neural component. It's usually worse in the higher frequencies. The conductive component is treated with bone conduction aids, sometimes bone-anchored, surgically implanted ones, sometimes just ones that vibrate the skull on a headband. And the sensory neural loss is treated with behind-the-ear aids or the cochlear implants. The hearing loss in charge can be progressive. It can get worse over time. Sometimes the conductive part gets better and worse with fluid in the ears. So if a child has a cold or just has fluid in the ears, the tubes have fallen out, be aware that their hearing may be worse in a treatable way. But the hearing can be better and worse day to day depending on the conductive loss. But the hearing loss as a whole can be progressive. I've known some kids that have had some hearing who have eventually lost it all. I've also had ones that have had hearing that was treated well with behind the ear aids, and by the time they were adults, they needed cochlear implants. So it can change over time. You really do need to keep going and going with all this stuff. Okay, finally we're to the genetics. I've been through the fifth of these major characteristics is the CHD7 mutation. We see that in about 80 to 90% of people with charge. And I just want to once again emphasize DNA does not equal diagnosis. It's one piece of the puzzle. Very important piece of the puzzle, but one piece of the puzzle. CHD7 changes are not found in everyone that has charge. And everyone that has a CHD7 change doesn't necessarily have charge. Okay, how can it not be found in kids that really clearly have charge? We're not sure. It's a very big gene. It's actually hard to look at all the different changes. It's possible that as genetic testing gets better, we'll find it in those. But the more likely explanation is that this gene works in conjunction with thousands of other genes. And if you have a problem, if these genes are working together, you have a problem with CHD7, you're going to get a bunch of problems. But maybe if you have a problem with one of these other genes that works with it, you might get the same set of problems. So there may be other genes that work with it that can end up giving you the same set of problems. And we know that that's the case with some things because The 22q deletion syndrome, sometimes called DeGeorge, it's the one that looks most like charge in terms of the features. Those two genes, they're best friends. They work together, and so you can really get the same set of problems with either one. You usually get slightly different looks to them, but not always. So that's probably why. We always recommend DNA testing. It's very helpful. It's especially helpful if you got somebody who's got a lot of features of charge, but you're not quite sure. If you then have a change in the charge gene, you say, yeah, that's the cause of the problems. Okay, if you're doing a clinical diagnosis, why bother with DNA at all? Well, it does help in the borderline cases. It's also helpful for family planning. But if you have a child with charge and you want to know if the next child is going to have the same gene, you can do testing for it. Just be aware that having the same gene doesn't necessarily mean having the same problems. So DNA tells you what the potential is. It doesn't tell you for sure what's going to go on. Doesn't tell you the severity of the features in any one child. I've seen identical twins with charge. So not only their charge gene is the same, all their other genes are the same. They have different heart defects. One of them needed a trach, the other one didn't. They were similar, but they weren't identical. Who knows? Blood flow during pregnancy. One was on the right, one was on the left. We don't know what changes these things. Okay, that's all the major features of charge. Again, the coloboma, the choanal the cranial nerve anomalies, the characteristic ears, and the gene. Those are the major features. You need to have at least 2 of those from a diagnostic standpoint. Moving on to the supporting features, there's sort of different categories of these. Again, some very specific to charge, but difficult to evaluate consistently. Some may be common in charge, may be very important medically, but so common in other syndromes that it's not helpful in saying, is it charge or is it something else? Most obvious one of that is heart. The heart defects in charge are often life-threatening. If they're there, they're really important to the family. They're less helpful in saying, is it charge or something else? So again, many of these supporting features are really important medically. And if something isn't present in the newborn period, that's less helpful for making a diagnosis early on. Some of these features we first noticed in adults, and back before the gene was found, we were often diagnosing children when they were 10 or 15 or 20 years old. What are some of these features? I'll go over some of these in more detail, but these are from a diagnostic point of view, these are the supporting features. Typical look beyond the ears, congenital heart defect, tracheal or esophageal anomalies, kidney problems, genital problems, and for purposes of diagnosis, cleft lip. For purposes of diagnosis, you can substitute cleft palate for choanal, even though they're really different. It doesn't really matter to you, it matters to the geneticists. Brain anomalies, there can be any type. There actually are some specific, I wouldn't call them anomalies so much as just changes in the shape of certain structures in the brain that have been described that may be unique to charge, that if you go looking for them can be very helpful, but most people aren't looking for them. Growth retardation, obviously, most babies with charge are normal sized at birth for their gestational age, so the growth retardation that we see isn't helpful because it doesn't show up till later, so it's less helpful. And some of the behavioral characteristics that Tim will be talking more about, some of those are very typical of charge, but again, we're not going to see them in the newborn period. What do I mean by the look? Well, we see some very typical things in the head and the face. We see a very square face with a broad forehead, round eyes. I mean, you come to a conference like this and you say, okay, you can tell who has charge and who are the siblings. The nose often has a prominent bridge, a square root, and a prominent columella. That's the tissue between your nostrils. It kind of sticks down more than in most people. Chin is often very small, gets larger with age. And it's really the same, we see the same features and the same frequency around the world. This is a collection of kids from all over the world, and you can see some of the similarities. Here are some older kids. The young lady on the upper left, you wouldn't pick her out of a crowd, but she had many typical charge features. She also had a brother who had charge, who had a heart defect severe enough that he died from it. The young man on the lower left was one I saw when I went to Japan about 20 years ago, and I was thinking, am I going to be able to tell who has charge and who isn't? Yeah, it was, but he was, some of your kids have been speaking to me in English, and I'm really impressed. This young man had a cochlear implant. He came up to me, and he says to me in English, "Where in America are you from?" I said, "Well, I'm from St. Louis. Do you know where that is?" "No, I don't know where that is." "Well, that's in Missouri. Do you know where that is?" "No, I don't know where that is." So I drew a little map of the United States with the Mississippi River going down the middle. Missouri is pretty much in the middle. So I pointed to it, and he looked at it, and he thought about it. It's a Japanese child, mind you. And he brightens up, and he says, "Far from the sea?" And I said, "Yes, far from the sea." That was a very, in his context, that was where in America I lived. And here are some teens and young adults. Obviously, these individuals are looking a lot like their family members, but there still is a typical face that we see. Some of them are short because of the hormone issues. You can see there's Philip again, the one that I get the picture of at every conference. Other things besides the face, we often see a short, wide neck with very sloping shoulders. There actually are some anatomical differences in the shoulders and the musculature that we haven't well described, but we see that a lot. There are often limb anomalies. When I saw the kids in Japan, 1 out of every 5 of the kids in Japan had extra fingers. In the U.S., I've seen missing fingers more often. And we sometimes see what we call the hockey stick palmar crease. And that's just, the palmar creases, they're simply fold lines. And where it folds depends on how long the bones are in the palm. And so it gives you information about sort of the shape of the bones underneath. And the hockey stick crease, that upper crease on the palm goes along, and for most of us, when that turns up and sort of heads between the first 2 fingers, it tails off. In kids with charge, it often gets deeper there, like the blade of a hockey stick. This is not unique to charge. We see it in other things, but especially in the early days when we had these borderline cases and they had these medical problems, and we say, well, does the whole child look like charge? That was a nice clue for us. So that's sort of some of the features that we see with the look of charge. Features that are common in other diagnoses, the most important is heart. About 3/4 of kids with charge have some kind of a heart defect that can be anything from a simple hole that closes on its own to life-threatening heart defects. They're often very complex, take several lines to describe all the different things that are going on. But some of the more common ones we see are tetralogy of Fallot, aortic arch anomalies, and other complex heart defects. And when I mentioned the 2 genes that are best friend, the 22q deletion, the spectrum of heart defects in that syndrome is identical to that in charge. If there's a child with tetralogy of Fallot, top on the list is 22q deletion, because it's about 5 times as common as charge. Second on the list is charge. Very common. So again, can be extremely important to the kids, but is less helpful in is it charge or something else. I mentioned facial clefts, kind of cleft lip and palate, cleft palate. This child has a repaired cleft lip. He also had kidney and genital urinary anomalies, which is the other thing on this slide. The kidney problems can be anything from a little extra fluid in the kidneys to a missing kidney to cystic kidneys. Any child in whom the diagnosis of charge is suspected needs a kidney ultrasound. A lot of these kidney problems don't show up making a child sick until it's too late to do anything about them. So if there's a potential kidney problem, you want to know about it right away. And about 30 to 40% of kids have them. So get the kidneys looked at if they haven't been. Tracheal and esophageal problems. The esophagus, the feeding tube, sometimes isn't attached to the stomach. It's esophageal atresia. Sometimes there's a connection between the feeding tube and the breathing tube. So you get air in the stomach, food in the lungs. Neither one of those is a good thing. You're going to hear a lot more about the gut and feeding issues from other people, so I won't go along that a lot. Some of the breathing problems, you can have I talked about the floppy cartilage in the ears. The trachea, the breathing tube, is also cartilage, and that can be floppy and can mean that the trachea collapses. Very serious breathing problem. That usually gets better with age. Other supporting features, short stature. That's not going to be there at birth, but it can be there later. Kids can have short stature due to a number of things. It can be due to medical problems. They can have heart problems, so all their energy is going to staying alive. They can have other medical problems. They can have growth hormone deficiency. We can test everything and not know why they're short. Genital hypoplasia. That's something that in boys, if they're born with a very small penis or undescended testes, that's pretty obvious. In girls, small labia is, people aren't used to looking at that and thinking about that. Absent uterus, you're not going to see unless you go looking for it. So those are things that are less obvious. And the absent puberty is not going to be there at birth, obviously. But it's fairly common in charge. A lot of kids they go through puberty if they're given hormones, but they need to be given hormones. So that's sort of how do you make a diagnosis of charge? But wait, there's more. Beyond the diagnosis, there are lots and lots and lots of other features of charge that may be important. They're not helpful with making a diagnosis, but these features of charge may be very important medically, developmentally, and educationally. Some are more common than others, but what I'll say before I give you a list of some of these is I think every single organ system in the body can be affected. Our very early conferences, parents would say, well, my child has kidney problems. What about that? Because we didn't recognize that at first so much. And we'd say, okay, how many of your kids have kidney problems? And people raise their hands and it's like, okay, we need to go look at that. So getting the families together and having them ask us questions was very, very helpful in figuring out what all's going on with charge. Here are some of these other features that are totally consistent with charge. Seizures, they can develop at any age. Apnea, problems with breathing. The sleep apnea can be either obstructive because of large tonsils and adenoids or brain-based. Floppy cartilage in the larynx as well, the voice box, as well as the trachea. Other endocrine problems, so thymic or parathyroid abnormalities, immune system abnormalities, everything from no problems to get sick all the time to severe combined immune deficiency because of an absent thymus. So can be the whole range. Extra or missing nipples, limb and skeletal anomalies. I mentioned the hand anomalies. There can be arm and leg problems, vertebral problems, scoliosis, craniosynostosis, which is early closing of the bones of the skull. All of those are consistent with charge. There are other problems that aren't sort of the physical problems that you can examine, but can be everyday major issues for the families, respiratory and anesthesia issues, gut issues. Kim's going to do a whole talk on that this afternoon. Constipation, potty training, how much of that is nerve-based? We don't know. Sleep disturbances, poor sleep, apnea, sensory integration. You'll hear more from David Brown, and behavior you'll hear more about from Tim Hartshorn. So all of these things are part of charge. I wanted to say a little bit about the variability in charge. Every single one of these features, and the ones I didn't mention, can vary from absent to 100% in any given child with charge. And as I've said, there's no one feature that everybody has. The vestibular problems is the closest. There's no one feature you have to have charge. So, people talk about charge syndrome, charge-like, typical, atypical. I think all those are useful. What's important is that any one child gets looked at very thoroughly. You know what particular set of issues your child has, and you deal with those. Exactly how they label it is much less important than saying, this is what's going on with my unique child. So, and once again, CHD7 isn't a yes-no, but it's very helpful, and it's part of the evaluation. Getting insurance to pay for that in the United States can be a problem, so I always talk about that a lot. Okay, parents say, well, does my child have severe charge or mild charge? And I've decided that that depends when you're looking. That when a baby is born, severity really has to do with can they survive. So in infancy, severity really refers to the life-threatening medical issues. If you can't get beyond that, none of the rest of it matters. If you get beyond those early life-threatening problems, you get to childhood, there may still be some ongoing medical problems that are really important, including eating, breathing, seizures. But by then, the sensory deficits and the behavior issues, the things that interfere with learning and communication, those become more important. So the medical issues are sort of hopefully dealt with, and the sensory and communication issues are much more important, because if you can't communicate, you can't learn, and where are you going to get? So in childhood, severity really has to do with that. By the time you get to adulthood, that's when you're really talking about intellectual capability. So in adulthood, severe and mild charge really relates to their ability to live independently or hold a job or have a meaningful life. So severity changes depending on when you're looking. You could probably break this down into 5 or 6 different categories. And again, I will emphasize that early medical issues do not predict how well they'll do. So, how well do they do? Well, your typical 2-year-old child with charge has spent 6 months in the hospital, maybe not all at once, but a couple months here and a couple months there, has had 6 or 7 different surgeries, is followed by 10 different medical specialists. We know this from asking all the families what's happened. So this is not guessing. This is what happens. And a lot of them haven't even hit the educational system yet. They aren't walking. They aren't talking. They're fed by G-tube. They got some pretty bizarre behaviors. And you look at that child and you think, oh my gosh, what's going to happen to her? Well, that doesn't tell you a thing. So you've got this child that's really delayed. Their potential is going to depend, how well they come out is going to depend on their potential and their environment, what's provided to them, how well they're supported. So what is the potential? What's the intelligence in charge? It's the whole spectrum. I'm a geneticist. I don't just deal with charge. I deal with all sorts of other things. Charge has the biggest spectrum of intelligence. It's everything from severely impaired to professional adults who've diagnosed themselves. I had an OBGYN call me up and say, I think I have charge syndrome. And he did. So it's the whole spectrum. The average is definitely shifted down, but what we see is that motor and language milestones are always delayed. That's just a given with the medical problems, the hearing problems, the vision problems, the balance problems. They're not going to walk and talk the same as other kids. But what I always tell parents is assume normal intelligence until proven otherwise. And you can't prove otherwise till they're probably 10, at least. And in fact, an example of that, at one of our conferences, we had a young man who got up, he was 24, and he got up to tell about himself. He signed, his dad spoke for him, and he said, "My name is Daniel, I live in an apartment, I have a dog and a cat, and I have a car and I drive, and this is my job, and this is what I like to do on vacation," and he told about his life. And he sat down, and his father got up, and he said, when Daniel was 11, he was lying on the floor looking at Legos. So early development just doesn't predict it. Now, if you don't do anything with these kids, nothing's going to happen. You really need to provide the right environment. So everyone is input impaired due to the sensory deficits. They're not getting information in. Many are output impaired. With the facial palsy, they're not looking you in the eye, they're facial palsy, they may have trachs, they may have limb abnormalities that make signing difficult. So there's a lot of information, it's sort of ancient computer technology, input and output with things. But what do we do about this? What do you do to give them the best chance possible? Establishing a communication system is the most important. Without communication, you can't learn. But ultimately, what happens? Early delay doesn't predict outcome. Some individuals with charge will become completely independent. Most individuals with charge will require at least some support throughout their lives, especially due to the sensory deficits. And some individuals with charge will require pretty much constant care throughout their lives. A lot will depend on their particular sensory deficits and their ability to communicate. You're going to hear more about this from David. What do I mean by sensory deficits? Children with charge have difficulty with hearing, have difficulty with vision, with balance, with smell, with touch. Basically, all the input information is coming to them differently. They experience the world differently. They learn differently. Let me see. Figure out where I am. I can't understand the next slide. Okay. So what does this mean? Sorry. Okay. Think about, you've got this vision loss, you've got this hearing loss. Why do babies do things that they do? Why do they hold their head up? Why do they sit? Why do they crawl? There's a world out there, they want to get at it. If they can't see it, they can't hear it, or they don't see it as well, they don't hear it as well. They're less aware that there's a world out there. The motivation for a lot of these things is really very vision-based. The ability to do it is a lot vestibular-based. It's harder to hold your head up if you don't know where it is in space. It's harder to sit and not fall over if you can't tell, you're getting the information just from your muscles. And David will talk a lot about how kids make up for this, so I'm not going to go on to that in a lot. I heard his talk yesterday, and he's going to be doing it again, so I know which things I don't need to go over. But if a major component of balance is missing, which it is in pretty much everyone with charge, they have to find other ways to work around it. And David will talk about that, so I won't go into that in great detail, but I will tell you about my favorite term on how to do that, how to think about that, and that is the communication bubble. How far out and how well does your child see? How far out and how well does your child hear? And those bubbles may be a little different, but I like it because it gives you a picture, And you say, really, anything that's outside of that bubble, they're not aware of. You need to get inside their bubble to communicate with them, to teach, and that sort of thing. And also, again, it's their normal. They don't know that other people's bubbles are different than that. So they're going to expect that their experience is the same as yours and really don't know any difference with that. Everyone starts out thinking everyone is just like them. And here's just a picture of some kids working within their bubble, very close up, exploring with their hands. You can also see this child's got a band with a conductive hearing aid. This one's got a behind the ear aid, but they're exploring with their hands, being very close up, and the people working with them are working within their bubble. And then I'm going to show you the really complicated slide. My mentor came up with this. In the handout, all this stuff is kind of listed on the next slide. But what this is showing is, on the left, is all the information that's coming from the outside. The vision information that's coming in, the hearing information that's coming in, the smell and the taste, all these, the senses, the information that's coming from the outside to the child. Someone has an opinion, okay? And then you've got all the things that are going on inside. What's going on with your swallowing? What's going on with your breathing? Are you tired all the time? Are you feeling sick? Do you have headaches? All this stuff from the inside, all this stuff, here's the information, and not as much of it's coming in. All these senses are impaired. All this crazy stuff going on the inside, and then you've got the particular child and their learning style. And as I said, this next slide just sort of goes over all these different things that are going on to just say their world is very different. There's a lot going on there, and you may have to modify things to help to know what's going on. And what's really, really important is that you know what's going on with your child, and that everybody working with your child knows as much of what's going on. And this isn't a static thing. This changes day to day. It changes over time. I know even with hearing, it sometimes takes several tests over many months to really know what's going on with the hearing. That may be true of vision too. But as much as you and everyone working with your child knows about what their world is like, the more you can adapt things and work within their bubble and get a communication system going. Once communication really kicks in, and they're able to tell you more about what's going on. A lot of things, you'll hear about this with some of the behavior things, a lot of the behavior is a form of communication, and sometimes it's intentional, sometimes it's not, sometimes it's frustration. It's like with typical kids and before they get language, you get the terrible twos is what we call it in English, where the kids that have tantrums. It's just because they're not able to, that's the only way they can communicate. And once you are able to establish communication so they can tell you what's going on, things often get much, much easier. It doesn't cure things, but things can get better. So find out about the visual field, as much as you can about your child's visual field and the acuity, how clearly they can see things. The doctors don't like to be imprecise. They want to tell you exactly what's going on, and they'll say, oh, I don't know. I can't tell you that. And you can force them and say, tell me, what's your best guess? What do you think is likely going on? I won't hold you to it. Just tell me what you think and get the best idea you can. What's going on with the hearing? Pay attention to fluid, fluctuations in hearing loss, balance. Physical therapy can be very helpful in helping them with the muscles and the tendons and all the other senses that give them information about where their body is. And communicate all this to various caregivers and work on communication. Okay, now we're going to do the fun thing. I was so thrilled to be given a longer time to do stuff because this is my favorite thing and I almost never have time to do it. And that is a deaf-blind simulation. This is not a charge simulation because I'm not messing with the vestibular and all those other things, the smell and the taste and the migraines and the breathing, and we're not touching that, just vision and hearing. But it can give you just a little bit of an experience of what it's like and how hard these kids work. So what we're going to do, and this is a picture of doing it. We do this with the professionals at our conference. And I didn't believe this. I thought, oh, I can imagine this sort of thing. I can think about it intellectually until I did it. And I thought, okay, I was wrong. You have to actually experience this to understand it. So what we're going to do is up here, we have a table full of things. I don't know if we have enough for everybody. If you actually wear very few of you wear glasses, so we can't do that. We've got these little plastic glasses, and we've got some blind spots put on them with blue tape. If you have your own glasses, you can put some on. It's just painter's tape. It comes right off. Don't worry. You're gonna put some blind spots on. We've also messed a little. It doesn't look like much, but when you put it on, you'll realize it's hard to read through them. So this is the vision loss. And if you're doing this for your own child, you can say, okay, he's blind in this eye and he's got a cold, but you can tailor this to your child's loss. So you have your glasses. Here's your hearing loss. These are just little foam earplugs like you can get at the drugstore. You squeeze them down, you stick them in your ears. This gives you a 30 decibel hearing loss. That's a mild hearing loss. Most of your kids, your hearing loss is much, much worse than that. But when we do this, what I'm going to have you do, and there's also some earphones and some fancy glasses, so hopefully there's enough for most people to try this, because I really do want everybody who can to try this. So you'll put your hearing loss in, you'll put your glasses on, and what you can do first is go back to your seat and do it, because when you do that, then or you can do it walking around, whatever, but have your hand out and look at it. Can you read it? Look up at me. Can you tell that I'm a woman? Can you see where I'm looking? Can you tell what my facial expression is? Okay, so think about all that. Look at what you can read. There's also a bunch of greeting cards, and they're in English, but that really doesn't matter. What I want you to look at is the colors, the contrast, the size of the type of writing. Think about what your kids get in school, the worksheets that they get, and various things. What can they see? What can't they see? And think about that, and what difference does it make? And once you've looked at things a little bit, I want everybody to move around and to find someone you don't know and introduce yourself and try to have a little bit of a conversation. And you find someone who speaks the same language you do, so you don't have to. You could put the earphones on, might actually increase the hearing loss a bit. That might actually be a good thing. But try and have a little bit of a conversation. And after we've done that for a few minutes, we'll have everybody sit down again, and then I want people to tell me what it felt like and if that gave them any insight into what's going on with their kids. So I invite you up to come and pick up your hearing loss and vision loss, and maybe pick up some of these cards and pass them around. Yeah, there's another one. He's got some back there too. Just put them on anywhere. Behind you.
I see you. You're a woman.
Yeah. How about the hearing?
It's very interesting. Famous.
I love doing this. It's, yeah.
Many things I know, but something is new.
Yes. Families, I do this talk at every conference, and families come back and come back and come back because they learn new things, or they go, that's what.
Yes, and many doctors don't know about this.
Yeah,
And,
they don't. Yeah, you're right.
yeah.
It's not really well, but I will try it, okay? Our son is 3 years old. He has the extreme problems. On the right side, totally off. It's not working. Maybe in the light, we don't know. On the left side, under 5%. So, my question is, in this context, because in your slides and in your presentation, you told that it's obvious and necessary to be the reaction. And our right I don't know, okay, told us we can't realize or see anything. This comes. So my question was, do you know which points are important for us
That's not good.
Okay.
Sometimes they do that because it gives them but it can make it more likely. Or if his behavior changes and it seems to be his vision at all, right away. The next day.
And in which interval it's useful to go to them to have the overview regarding the status? As in 1 year, as we he's a professor in a university clinic.
For children's eyes?
Yes.
Okay. At least once a year, more than 2 times a year would be
Better, huh?
Yeah.
Stimulation. Yes, you can't pull it.
Walk around and see how hard it is to walk around.
But he is.
Okay, can we call people back now?
Bin ich an? Ja, ich bin an. Also, ihr dürft euch wieder hinsetzen, aber ihr dürft gerne die Brillen dran lassen, auflassen, aber setzt euch gerne noch mal hin. I know. Okay. So, wir würden gerne weitermachen. Achtung,
So we'd
Achtung.
like to continue. Hello,
Caro,
everybody.
machst du mal die Tür zu?
And maybe we can close the doors.
We will still get you all out a little bit early. Okay, you're welcome to keep the glasses and the earplugs. And in fact, if you want to try this with any of your teachers, there's some extras up here that you can take. I'd like to have people, what did you think? What did you feel like? Who can tell me what it felt like? Okay.
For me, it felt very...
German is fine.
Okay.
Yeah.
Also für mich war das sehr irritierend.
Okay, then in German. To me, it was a rather confusing experience. I had the feeling I really had to make an effort to see and hear everything, purely hearing-wise, but also seeing. I found that even more exhausting because, yeah, there's no escaping it. And whatever I do, I always have the feeling I've got to move my head upwards. And it was very confusing and also very irritating.
Okay, who else? It's coming from the other side. Oh.
Ja, ich gebärde, deswegen muss das Mikro woanders hin. Ich bin ja schon...
Yeah, I use sign language, so the mic has to go elsewhere. I am deaf already. Usually I have good vision, so I put on those glasses. And of course, I would usually like to talk to people, and it was very annoying to me if somebody speaks to me. They would usually tap me, and it took me quite a while to figure out where that person was standing, or I had to be led there. And also this bending your neck backwards that really causes neck pains. So this visual impairment on top of me not hearing anything. I think I really have a better idea now of how a child feels that has a visual and hearing impairment.
So just vision and just hearing is enough. When you combine it, it's different, and it's even more exhausting. And remember, the kids can't take it off. Who else? Anyone else want to say what it felt like?
Also und ich empfand das halt auch als äußerst anstrengend.
I also found it really, really exhausting. And I have to say, after this really short test only, I now admire my and our children a lot more, how they manage to still go through their development steps and master it all and compensate for all of that. I must say, yeah, it was an eye-opener. I'm really flashed, we say, what they managed to do despite of all their handicaps.
Thank you. That is exactly what I want to get out of this experience, that it truly is different to experience it. We did this for less than 10 minutes. At the end of 10 minutes, people had taken it off. It's exhausting. And I didn't even mention that the kids often have neck problems. They're doing this all the time, but there are also vertebral problems with the necks and weak upper bodies, so it's even harder for them to stay upright. So there are fatigue issues beyond the hearing and the vision. There are muscular fatigue issues that the kids have. And anyone else want to add to this, or is this pretty much the experience that you had? Yes, no? I've done this with high school kids, and I had one group of high school kids that left the glasses and the earplugs on after class when they went to the cafeteria. And really, it was very interesting because with the high school kids, I said, okay, if you pass a classroom and you see a child in there, what do you think? And they think, oh, I think they're retarded. I said, what do you think now? I said, they just can't see very well. So this is again, it's something that you really don't get until you try it. You can't understand it intellectually, which is why I figured out a way to do it with the simplest materials. So this can be done with the brothers and sisters. This can be done with the aunts and uncles and grandparents. 5-10 minutes, it's all it takes. If you have, grandparents that are saying, well, why don't you just do whatever with the child? Give them a little bit of a taste of the child's experience with other caregivers, with teachers, especially if you can, okay, they're blind in one eye, and do it so that it is similar to what they have. But even if it's not similar, even if it's just a little bit of vision and hearing, realizing how much harder these kids have to work to get the information in. And that's what absolutely convinces me that these kids are way smarter than anyone's giving them credit for, because they find ways to do so much despite all this. And again, all we messed with was with hearing and vision. We didn't do the vestibular, we didn't do the smell, we didn't do the pain. There's so much more that's going on. And why things change, it's no wonder these kids need rest breaks during the school day, that they get frustrated with things, that just so many of the behaviors, if you think about it in terms of how hard they're working all the time, not just in school, but at home to communicate with you, everything else, that walking a mile in their shoes, as we say, a kilometer in their shoes, is something that's really, really important. So if you want to take any of these materials, please do. I'm not taking them back. I'm sure Claudia would probably find a use for them. But if you want to take any of these to try with anyone, please, not the earphones, but the stuff I brought, help yourselves, the cards, any of that. And I'll just say that there's lots of information on your website. There's lots of information on the U.S. Chart Syndrome Foundation website. And, thank you so much for having me here. And I'm doing the consultations too, if anybody wants to try. I really look forward to meeting some more of you over the weekend. So thank you. And if you have any questions, there is time for questions if anyone wants.
Fragen? Nein, sieht nicht so aus.
Are there questions, says Claudia. Doesn't look like it at the moment. Thank you very much, Meg, and thank you. We will now indeed break for coffee, and we'll continue at 4:15, 4:15, with Kim's presentation. That is more about the medical aspects. A super fascinating topic, I can only recommend it.
Genau, also wie gesagt, wir haben eine kurze Pause.
But again, now it's a coffee break. All of the rooms should be ready now if you want to check in. And at 4:15, we'll be back here for Kim's presentation. See you in a bit.